We will now proceed to our Q&A session. Thank you to all the surgeons who submitted your questions. We will try to answer all of you. If we run out of time, we will answer you through email. The first question is for Dr. Lim. How many types of dental product does Osteopore have? And since Osteopore is using 3D printing technology, as a surgeon, can we design our own osteomesh?
Hi, Aline. Yeah, thanks for the question. So we have I presented during my presentation earlier that we have a dental plug that's for socket preservation. And we do have a variety of osteomesh that's meant to be used in various GBR applications, as Dr. Kumar has presented, and also one of the case study that I've shown earlier. I think naturally the benefit of having a 3D printer as a manufacturing tool is that we can quickly prototype. So I think, broadly speaking, if there are certain needs that you see in clinics that you think may be addressed by our technology and products, we'll be most happy to come down to have a discussion with you and see how best we can then adapt that to your needs.
Thank you, Dr. Lin. Our next question is for Dr. Kumar. What are the indications in using osteomesh with bone graft and without bone graft?
Okay, so this is okay. So I saw a question earlier from someone who talked about the quality of the gingiva post surgery. Says Roshan John says in the central incisor case was not happy at all with the final gingival condition. My point of view. Now, I'm not here to show you my best cases. I'm here to show you all the cases, or at least a sprinkling of cases where I've had good results, bad results, and moderate results. The reason is because this is something which is a work in progress. When I first started, I told you I started using the mesh with particulate bone graft, with PRF, because I was, for any other word, kiasu. I was afraid to lose. I was afraid that I would lose the case, afraid that I would mess the case up. Hence the reason why I decided to use all three. As I got more braver, of course, I decided to use just osteomesh with PRF. And now I'm using cases routinely without particulate bone graft, without PRF, and just the osteomesh alone. So in terms of what I am doing now, if I see a case where there's a substantial amount of bone loss, bone volume loss, especially in the anterior maxilla, for those of you who do all on fours, for example, and certainly for those of you who don't do all on fours, please don't go to sleep yet. I'll tell you more. For those of you who use this in all on fours study, it's very clear. In the anterior maxilla, there's a lot of concavity. The patients always become pseudo class 3. I would use osteomesh, a thicker version of it. You can see that, of course, you can choose. And I would use a particulate bone graft with it. To me, all particulate bone grafts in the mouth, I try to use, with the sole exception of internal sinus lifts, I use all bone grafts in the mouth with PRF. Okay, the results are fantastic. Now, with regards to minor defects following, for example, a central incisor, lateral incisor sort of implant, if you want to raise a mucoperiosteal flap and if there is concavity which you want to restore, I would use in these instances just Osteopore on its own. You shape it, you cut it, make sure you don't use the border around it, and you can certainly use it without anything else. And the whole point is, if you imagine, you're trying to just keep that bone, the clot in there to form bone, just anterior to your implant. I hope that answered the question.
Thank you, Dr. Kumar. Our next question is for Dr. Lim. Can you explain more of the thermoplastic ability of the mesh, how long it can maintain its shape?
Yeah, Aline, thanks for the question. So polycaprolactone is considered a thermoplastic material, and based on the material characteristics, it is very pliable and elastic at room temperature. In terms of moldability and ability to maintain its shape after shaping, based on what we have tested and understand, the material can be shaped multiple times in warm water. And after it has cooled down to room temperature, it can maintain its shape even for extended periods of time at body temperature. So we have done a test in our labs, and we have demonstrated that the curvature that we obtain during the shaping process can be retained for a longer time.
Thank you, Dr. Lim. Our next question is for Dr. Kumar. From your experience in stabilizing the mesh, is it difficult when suturing it to the periosteum? Any suturing tips that you can share with us?
Okay, thank you for the question. Okay, number one, I don't suture anything to the periosteum unless you consider mucoperiosteal flap to hold the periosteum. Because to me, when I raise the flap, I'm raising the periosteum to with the mucosa. So it's a mucoperiosteal flap. So the mucoperiosteal flap is now in an apposition with the most buccal aspect of the osteomesh, if you like. Now, for me, I've used plenty of tacks before, bone tacks, both resorbable and non-resorbable. My experience is that it can give you a fantastic sort of stabilization of both membrane and clot. But I've been trying to use osteomesh as far as possible passively so that it doesn't move. So how do I stabilize this? I use a lot of silk in my practice. Okay, and of course I tend to use resolvable sutures like Bicure, for example. I will then use a suture through the osteomesh to the opposite side. So for example, I'll go palatal, I will then go into the mucoperiosteum on the opposite side, but it'll be literally to the periosteum and it will not come through the gingiva, okay? And then I'll use it as an anchor suture. You only need two of these. Once you do that, your osteopore membrane is not going anywhere. But as I tell you before, as before, my experimentation has not stopped. I've now used Osteopore literally by making a pouch in the case of a single implant. I use a pouch, a tunneling technique, and I place a small amount of osteomesh inside. And to me, I do not need to go and stabilize this because I've just made a pouch. But for those cases where you have very large amounts of mesh use, you will need to stabilize this. And in my understanding, whichever works for you, you should use. However, in my hands, I find that suturing with the non-resolvable suture is more than sufficient. If you have decent amount of tension, although it should be tension-free closure, there must be some tension to allow the osteomesh to stay in place. So I would say, in a roundabout way, use sutures as much as you need. I personally will not use tacks anymore in my practice for various reasons. Of course, there will be some of you who did choose to defer. It saves me a lot of time not using the tacks. But the very fact that the osteomesh is so wettable with blood, it should stay where you need it to stay.
Thank you, Dr. Kumar. Another question for you. Between the thick or the thin mesh, which one do you recommend and why?
Okay, so when I first started off with Osteopore, I told them I wanted a mesh that is, I was going to use it for immediate implants, of course. So my dream was to place an implant, for example, a molar. I wanted a mesh which could fall on the buccal and lingual aspects. So I talked to them with my wish list. Lim Jing couldn't give me my ideal membrane at that point of time. So they made me a very thick, ugly looking mesh. But I still used it anyway. So I was not going to give up. And after that, I said, look, I'm getting extrusions and stuff like that. So eventually they gave me a very thin mesh. So this thin mesh came with a border. So I said, what's this border? Why can't you remove it? And he said, it's part of the manufacturing process. So I said, you know what? I said to my nurse, I'm going to cut this bloody border off. And so I did. And after I did, I found that there were less problems. So I find that the use of the mesh in terms of the thickness and size, if you want to, it is basically based on experience, okay? But as far as I would say now, the one that I use the most is the thinnest one. And if you want to use the thinnest one, you can always bulk it up by just doubling it. And you don't have to use the thick one anymore. However, in the anterior maxilla for complex reconstructions for atrophic maxillas or even atrophic mandibles, you can certainly use a thicker version of the osteomesh.
Thank you, Dr. Kumar. Another question for you. Since you do not use membrane to cover the mesh, are you not worried about mucosal ingrowth?
Okay, so this is I expected the periodontist to ask this question. I, of course, asked this question to Lim Jing the first time we met, didn't I, Lim Jing? I asked you about this question. I said, I'm concerned about the ingress of oral epithelial cells that will cause encapsulation of the implant, encapsulation of whatever I put inside. I asked this exact question, of course. Now, if you look at the studies that Osteopore actually has, many of the studies that they've done actually on pediatric cases, in fact, pediatric calvarial cases, calvarium. And In those instances, their results show that there's no bone, there's no encapsulation, which means no fibrous tissue growing around the osteopore, and then which means that it's healing with proper bony healing. So I haven't had this problem so far. And of course, as I said, I used PRF initially to just keep myself sane and not worry about the fact that this was going to end up being just a horrible mess of granulation tissue. But at current time, I do not use the membrane. If you notice all the studies or cases that I've shown you, I've not used the membrane. The membrane I have in this case is the Osteomesh. And of course, some of you will talk about the fact that there are lots of pores. The pores have been studied by Osteopore to be the ideal sort of size to allow infiltration of blood vessels, of course, and of course, there's both vascular and angiogenesis to happen. I haven't had a problem with regards to wanting to use the membrane on top of my Osteopore. I seriously am hoping that this is my preferred membrane at this point of time, so that I do not have to use the particulate bone substance as well.
Thank you, Dr. Kumar. Another question for you again. What are the other types of surgeries that you plan to use Osteomesh?
Okay, so actually the first thing I wanted to speak about to Osteopore as a company was to see, they were very receptive in terms of what I wanted, okay? For those who know me, I'm very, very keen in research, and I'm absolutely mad about bone biology, okay? And one of the things I said to them was, I have a problem. I have a lot of buccal bone loss after an implant is placed in the, for let's say, lower left 6, lower left first molar. And then I also have a huge defect around it, which I don't really want to place a particular bone graft for because of extrusion and stuff. There are plenty of periodontists, plenty of max spec surgeons, plenty of dentists who will show you some amazing pictures of packing bone graft around immediately placed implant, okay? And some of them pack it so hard, I wonder how much of blood is actually going to get there and form new vessels. I wanted something to keep the blood clot inside. I wanted to stabilize the blood clot and just use that initial blood that would come through to form new bone. And I also wanted to maximize the buccal gingival, especially the buccal gingival sort of post-implant sort of loss of anatomy, loss of shape, loss of a contour. And for me, by wanting all these things, I came to them and said, look, guys, I want a solution for this. And so we came up with plenty of solutions of how we were going to achieve this. And the current membrane that you have now, interestingly, the thin one, the exact membrane that I needed to use for the immediate implant placements. So although that's the first thing I wanted to use it for, it's actually now that I've actually got the material that I want to use for my complex cases. In terms of where else do I see these being used? For those of you who believe that you need to have some form of soft tissue, connective tissue graft, or for example, some form of buccal bone onlay for anterior implants, especially the maxillary anterior implants, I would actually make a very simple, very small pouch and slip some Osteopore inside, because it will retard the rate of resorption. And after all, you know for sure it will disappear within 18 to 24 months. I have to say this to you at this point of time. It is extremely technique sensitive if you haven't learned how to use it. So your first 1 or 2 cases, you might have a bit of a learning curve, but after a while, you will reach for it as your only, in a particular case, you would say, this is my favorite sort of material of choice. Where else would I use this? I would use this wherever you need soft tissue augmentation. In this case, I'm talking to you about how I allow the patient's nasal projection to be improved. I want the patient's lip to be supported. I mean, look, we can support the lip with the acrylic, of course, we're using a denture, but is that nice? If you want to support the lip using something that's bony, I certainly am not going to be putting bone plates or any form of harvested, fibula or hip graft to put on the maxilla. A very simple piece of Osteopore does the job. And of course, it's an advanced technique, of course, but if you are invariably doing all on fours, you would be raising a full buccal mucoperiosteal flat, in which case it takes nothing in terms of time to place that something that is going to resorb anyway, to give that additional bulking to what has been lost by the patient due to the process of aging. Where else would I use this? I asked Lim Jing, of course, whether I could take Osteopore and shred it and beat it into powder. I have come up with so many questions. They have successfully made me avoid trying all these experiments on my own. I have to say to you, if there was any other techniques that potentially could be using in the oral mouth, for especially with dental implants, I probably would have thought about it. But if you have any ideas, please send them through, because I've tormented the Osteopore team and pushed them very, very hard to give me the product that you guys will be using at current time.
Thank you, Dr. Kumar. Another question for you. Can we use Osteomesh with sonic-weld resorbable screw in CMF cases?
All right, so I used sonicwell when I was working in England many, many years ago. It's fantastic. It's very quick to use. I haven't used sonicwell with Osteomesh, but I spoke about sonicwell to Lim Jing on the second time we met, didn't I, Lim Jing? Sonicwell. And I told him, I said, look, sonicwell just might be the amazing thing. So no tax, we can keep it in place. After using Osteomesh, I realized that it doesn't migrate that easily. Okay, in terms of migration, there are two types of migration. Okay, early migration and late migration. Okay, early migration, your graft is nowhere near where you wanted it to be. In late migration, you'll see the anatomy which you wanted to restore somewhere else. Now, I've not had this problem with Osteomesh at all. What I've had with Osteomesh is extrusion of the sides. And the reason for that is because I did not remove the borders, or I've used too thick a product. In which case now, I don't see any need for me to use either a sonicwell, a bone tack. The simplest thing for you to use would be to use a resorbable suture, Vicryl, for example, and you would be able to fixate the membrane. In general, the less you use is better.
Thank you, Dr. Kumar. We will now take the last question as we are running out of time. And the question is for Dr. Kumar again. What do you think of the PCL as material?
PCL as a material is fantastic. Okay, if you belong to the philosophy that I have with regards to any form of membrane or dental biomaterial, if I'm going to be using it to create bone, I essentially want it to be able to protect that volume of clot. And in that case, one should argue and say that titanium is a great substitute, or should be your first port of call. Titanium mesh, any form of membrane which has memory would be a useful way to ensure that space doesn't disappear. But the problem we have with all of these things is that, for example, in titanium, for me, the moment I strip off a mucoperiosteum, okay, to me, I'm injuring that periodontal complex. I'm disrupting all of that. I'm stripping off all the true attachments that the patient would have otherwise lost. So for me, as far as possible, I don't want to be doing that. Now, for me, in terms of how I want to make this work for myself, Osteomesh has allowed me to use a product which is obviously gone through a few iterations, of course, but if it's safe in my hands, there's the most it's safe. Two, it can dissolve with time, which I've already seen in my own hands. Three, it has not attracted any form of infection on the buccal aspects. I've had two instances where I've had to remove the membrane, but it was because of me wanting to push the membrane even further. I won't discuss what I use it for this case, but the next time I'll present the case in detail. In which case, the vast majority of the times, I've not had infections with Osteomesh. Certainly for more than 95% of the time, as I said before. So for me, Osteomesh is a very, very safe material to use in my patients. And of course, if those of you who are biologically interested, those of you who are holistically interested, if you want to use a membrane that is not of any form of animal origin, here you go. A product which has basically metabolizes to carbon dioxide and water. Now, the only small gripe I have, of course, with the handling Osteopore and Osteomesh is that many of us don't have access to a hot water bath. Okay, so I have come up with my own techniques around this, of course, and this is still not actually published in the literature they've done for me. And they've been very kind to use my surgical technique, taken photographs of what I've done and made into cartoons for you to see. I actually now cut serrations into a membrane. I cut serrations here and here to allow it to bend. Okay, and then change, of course, the corners and the sides to allow for me to go around a curve, for example, around a canine eminence, for example. And this is how I use the product. So in terms of what it does for me, it ticks all the boxes I have. Is it the ideal material for me at this point of time? Probably the best that I've used up till now. There's some instances where I can't use, for example, in a case of an internal sinus lift, I talked to Lim Jing about this. I said, look, I'm going to take your osteomesh, cut it up into pieces, pound it, and I'm going to put in some internal sinus lift. And he said it won't work. And of course, I didn't try that. Okay. But for me to use it, for example, on a lateral window sinus, I would just use that and just place it over once you've done your lateral window elevation, lateral sinus wall elevation, put a bone graft inside with sticky bone, hopefully. Then we'll put osteomesh on top of it, and that's it. I will close it. I wouldn't even need to tack it down. I've never needed to tack down osteomesh on a very large defect, in this case, a bony window after a lateral window sinus lift. So for me, it ticks all the boxes at current time. I haven't seen the need for a custom sort of a plug, for example, to be made. Custom plugs are all very nice to write in literature, you know. But in terms of practicality, I said to Lim Jing and team, whatever a dentist uses, especially a general dentist, for me, I want to use it straight off the rack, straight off whatever my nurse gives to me. I want to be able to use it immediately. Big size, small size, doesn't matter. The point is that I want to be able to use it with as little manipulation as far as possible. As little time as some for example, some products that say, oh, you have to soak it for 15 minutes, 10, 15 minutes. I don't want any of that. I want to be able to use it as quick as possible. So at current time, to summarize, Osteopore fits and meets all my needs. I'm just sharing these findings with you because I just found it very interesting that such a product is working so well in my hands. We are looking forward to publishing these very shortly. I thank once again the Osteopore team to providing all these lovely illustrations that you've done and some videos which I would have not been able to have seen otherwise. Thank you very much for inviting me to speak, and thank you for the last question.
Thank you, Dr. Kumar. We have now reached the closure of our webinar. In behalf of Osteopore International, I would like to thank our speakers and our attendees for spending time with us. For all the SDA members, kindly check your emails and we will send you the form for your DCR number. And to everyone, you can visit our website and contact us if you have any inquiries. Thank you and see you next time.